Thank you to the Hindu group, thank you to the management committee of MIOT International for giving us the opportunity to come and give the talk on epilepsy and its management. Being a neurosurgeon, I would be focused on what are the surgical options available to manage and cure epilepsy. This slide shows a very interesting number, 4994. It's a palindrome number. If you can read from both backwards and forwards, it's going to be same sequence. The importance of this number is that a person who started on one medicine has about 50% of chance of being free from epilepsy. However, when two medicines are required, that number drops down to just 9%. That means only 9 out of 100 will have some control over epilepsy. What if we add 3 medicines? Hardly anything, 4%. That means 96% of patients will continue to have epilepsy despite being on 3 medications. What if the surgery is offered as an option? It has a potential to treat about 50 to 95% of patients depending on the type of epilepsy, depending upon the networks associated and various other factors. And this clearly shows that any patient who is on 2 medications and more has a significant chance of being able to cure of his illness, cure of his epilepsy because of a surgical option. And this is what is known as medically refractory epilepsy. To sum it all, surgical options are nothing but 3. Basically, finding where the problem is in the brain. Once the problem is found, to burn it. Literally doesn't mean by burn we put in some fire and burn it. We use surgical tools to have a precise destruction of the tissue, or stun the tissue, stun the abnormal tissue. It's just like defibrillating the heart. It's quick starting the heart, jump starting the car. It's similarly, this is called as neuromodulation. And neuromodulation, like vagal nerve stimulator, can be used to jump start the brain. Things like deep brain stimulation can be used to jumpstart the brain and correct the cause. Now, to give the enormity of the problem, it's very simple to say find it, burn it and buzz it. But however, just to give a brief idea about the complexity of the issue, this is a photograph and you can see a lot of parakeets over there. And for a moment, please look very closely in this photograph and try to identify a butterfly. There's a butterfly hidden somewhere, and name the color of the butterfly. You got 10 seconds. I'm going to wait over here. In Q&A box, you can say or you can write the color. Sorry, I think I've already given you that. Color of the butterfly. And imagine these parakeets to be normal neuronal cells, normal brain cells, and they should not be disturbed at all. And our role as a surgeon is to pick up the butterfly and then remove it from the cluster of the birds which you can see. So the time starts now. For next 7 seconds, if you're able to identify that butterfly and the color of the butterfly. 1. Please put your responses in the Q&A box, those who are listening. 1, 2, 3, 4, 5, 6. Right, let me give you the answer. So there it is in the yellow circle, small butterfly with the color, it's pink. I'm sure that people are it's very easy to now recognize that. So just this complexity magnified into 1 billion or 1 million or 100 million. And this is how we go about finding that abnormal focus which is really responsible for abnormal activity arising out of the brain. And this figure also shows that the area which is enveloped in orange, that orange area which encompasses a problematic zone from where the abnormal electrical activity is starting, the symptoms where they are arising from, and any lesion or any tumor or anything which is associated with that. That entire orange zone is our target, and this is what we go about finding. And that orange zone is known as epileptogenic zone. And there are various strategies and various multidisciplinary things which are required to identify the correct candidate with an epileptogenic zone which can be addressed surgically. So a participation or multidisciplinary team is required to find out that epileptic zone and associated networks. So you need a participation of specialists like Dr. Bindu, who is a specialist in epilepsy, neuropsychologist, the neurophysiologist, our nuclear medicine specialist, and various other interdisciplinary people to identify and get across and find out the right candidate who would benefit with surgery. If you classify the surgical procedure, what is done for the epilepsy, the few procedures are for the diagnosis. That means to finding out the abnormal area in the brain. And there is something called a therapeutic. Once the area is found out, either, as I said, you burn it or resect it or you remove it, or you stun it or you do neuromodulation. That's what it essentially means. And resective surgery essentially involves removal of a lesion or an abnormal area which is seen on the MRI scan. Sometimes it is seen on the MRI, sometimes it is not seen on the MRI scan. Or disconnect an abnormal area from the normal structure so that the electrical activity, the abnormal electrical activity, does not spread in the surrounding normal brain. Zapping the brain or stunning the brain involves either something called as vagal nerve stimulation, where one does not even need to open a brain. The vagal nerve is situated in the neck, and a pacemaker device can be placed within the vicinity of the nerve, and that can create electrical impulses which can normalize the electrical activity of the brain. Another form is deep brain stimulation, which also can be utilized in some form of epilepsy. So one would ask, how do you decide about resective or removal or neuromodulation or vagal nerve? It all depends on the age of the patient, the type of epilepsy, the localization of the network, and the characterization of something called as epileptogenic zone. We'll just try to understand by taking few cases. This is a 15-year-old child, female, presents with multiple episodes of seizures, about 3 to 5 episodes per day, leading to fall and frequent hospitalization. She's on multiple medications, huge dose, and medications per se, they're causing drowsiness, sleepiness, lack of memory, concentration, and other things. So this patient is being evaluated, and the MRI scan and a PET scan is being shown. The PET scan is colorful structure which you can see in green, blue and red and orange. MRI scan is black and white, and the arrow points towards an anomaly which is seen in something called as temporal lobe, which is located in the area above the ear, the right ear. And we also do something called as prolonged EEG monitoring. EEG is nothing but measuring electrical activity of the brain, and the EEG activity of this child corresponded or pointed to the problem located in the temporal lobe, as you can see in the diagram alongside. So this child, once we have localized that the problem is in the temporal lobe, and once we have ascertained that the memory is not going to be impaired after removal of this focus, then we embark on a procedure which is a resective procedure to remove this abnormal area. And that's what you are able to see on the right side panel. You can see the abnormal area documented in the white, and this area is removed on the adjacent panel. And this surgery is called as right anterior temporal lobectomy, and this is done under microsurgical guidance. A high-end microscope is used, and this is the human brain, and these numbers are actually the various areas which are being monitored for abnormal electrical activities, and that area is being identified, and slowly and gradually under microsurgical computer navigation guidance, this area is removed. You can see that abnormal area being removed, and the adjacent area which is also looking abnormal, that is also being removed gradually, slowly and steadily. There's another area which is close and deeper, which is responsible for the memory and making sure that memory area is not impaired, various neurosurgical tools like robot, like neuronavigation, intraoperative continuous monitoring of the brain data. All this thing is being done very gradually and carefully, making sure that we are not giving any complications to the patient in terms of memory loss, paralysis, coma, or any other thing. So this child has had this surgery done and had an excellent outcome with seizure freedom being achieved. Second case, just a 6-month-old infant with some history of oxygenation issue during the birth, and the child has been having severe seizures since the second day of birth, 5 to 6 times per day, multiple episodes, and child's growth in terms of brain development, movement development, language development is not improving. It's something called as neurodevelopmental decline. Child also has a weakness, the right side there is a weakness involved, and every possible drug combination in the world appropriate for this kind of epilepsy has been tried. And I'm not going to the elaborate list. Even the ketogenic diet, which Dr. Bindu just mentioned and emphasized on, that's been tried. Despite that, 5 to 6 times severe seizure, leading to something called as catastrophic epilepsy. Again, EEG shows catastrophic epilepsy. MRI shows, if you see, this is the right side of the brain, this is the left side of the brain. The entire left half of the brain is malformed, it is ill-formed, and it is discharging abnormally. So this patient underwent something called as functional hemispherectomy, where this abnormal tissue, which is not doing anything productive but just discharging abnormally, is taken off, and very good result following the surgery. The 2 years following the surgery, the child remains seizure free, and not only that, at the end of 3 years, the child gained all the language, motor, and other cognitive milestone which patient was not able to do that before. Case number 3, which does not require any cranial opening, head opening, 18-year-old male with staring spells. He has a continuous staring spells, brief, lasting for about 2 to 3 minutes, followed by severe seizures involving jerky movement of both hands and legs every month, with severe disability, not being able to go to the school, not able to write, not able to learn new things. And again the same story, 1 medicine, 2 medicines, 3 medicines, 4, see the 5 medicines have been tried and nothing is being controlled. And here he undergoes a very elaborative evaluation in our epilepsy board, EEG, video EEG, PET scan, MRI scan, everything is normal. However, the EEG scan shows that there is an abnormal activity which is coming up from both the hemisphere, and there is no one particular area which is responsible or identifiable for production of these kind of seizures. So these kind of difficult epilepsy cases or generalized epilepsy, and in children there is something called as Lennox-Gastaut syndrome or genetic generalized epilepsy. Vagal nerve therapy is very, very useful. And during vagal nerve therapy, as this cartoon demonstrates, there's a pacemaker device which is placed on the chest wall, and there's a wire coming out through that, and the tip of the wire has got a small micro electrode that is placed on the vagal nerve, which nerve is directly connected to the brain. And this device is so fantastic that it senses the oncoming seizures, and before it can convert into a major seizure, it will start discharging. And once it starts discharging, the electrical activity, specifically the abnormal electrical activity of the brain, that becomes controlled and the patient no longer has seizure. So in this case, as I described, with various current settings, patients became seizure free after 3 months after the implantation, and he was gradually weaned off of 5 medications, and after 3 years with a single medicine, he finished his schooling. And I'm very happy and proud to say, and this is what he gifted us. He was not able to read and he wanted to learn new things. This is how he came up with a brilliant and beautiful drawing after VNS, maybe after 2 years after implantation. And we were so happy to see this outcome, which was not possible without having a collaborative teamwork and a very proper evaluation process. So I will stop over here and sum that surgery is definitely an effective treatment not only to control but also to cure epilepsy, especially in medically refractory epilepsy cases. However, we need to have a teamwork, and this kind of a teamwork is not there in most of the centers in India, and there exists a huge gap between the demand and supply. And here in Mayot International, as a team, we are here, and we are here to pave the road to cure in epilepsy. This is our epilepsy team. You see, there is no one particular person who is responsible for the epilepsy. It's a team. There are so many people who have been illustrated in this team, and I'm very proud to have each one of them with a unique ability and a passion to treat the epilepsy. It's not control. We are talking about curing the epilepsy, and we strongly believe that as a joint effort, we can indeed achieve that.